So I think we'll make a start. It's just after 2 o'clock. I'm Alan Cameron. I'm the obstetric clinical lead with MCQIC, and we're very pleased to have this webinar for you this afternoon from the maternity and neonatal care section. And the theme today is going to be on term admissions. I'm delighted to see so many people are going to join us, and thanks for taking the time out your busy clinical schedules to join. I'm sure it's going to be a good webinar. We've got, I think, 42 I can see on my screen so far, but I think we've had expressions of interest from more than 80 people. So maybe others going to join. Short of time, so I think we will just make a start. You can follow us on Twitter if you're tweeters, a bit like myself and Colin. At MCQIC SPSP is the Twitter handle. I think that's the word. So as I say, the theme today is going to be on term admissions. In terms of housekeeping, well, we are recording this session as you've seen on the previous slide. Aims of the day are to provide networking opportunities, obviously, for maternity and neonatal staff, and to offer the sharing of learning and experience reducing term admissions of neonates. In terms of the housekeeping, sorry, the slides just come up for me. As you can see, please keep your microphone on mute and your video turned off to avoid any background noise, and then also to minimize the likelihood of slowing down the technology. And if you want to take part in the discussions, use the chat box, which you'll see on the screen. It's very easy, or raise a hand to ask questions. And some of us are able to, we're going to screen the chat box and we'll field the questions through me, okay? So if you're going to speak, unmute your mic, obviously. The most commonly used phrase during this whole COVID epidemic has been "you're on mute." So yeah, remember to unmute yourself before you come on. Turn on the video if you have to do that. Speak, remute, and turn your video back off again. So it's fairly simple, but if you haven't used it before, I'm sure most of you have. Working in the health service, you've been using this technology quite a bit. So here's the agenda. As you can see, it's fairly full, and we'll try and obviously keep to time. We're aiming to finish at 3:20. So we're on track at the moment. We're going to have an icebreaker first. I've never done this before, so this is new for me. Let's have a bit of fun. So this is through the chat box. So basically, we want to get people just in the mood for using the technology. We want you to pick a symbol, pick an emoji from here about what best sums up how you feel today. So just a bit of fun to begin with. So we'll give you a minute to do that. There's lots of interesting expressions there. So just pick one and we'll have a look on the chat box to see how people are, and we'll come back to you later on that. So we'll give you a minute to do that. Oh, there's lots of good things coming through. Birthday cake. Oh, is somebody having a birthday? Yeah, lots of interesting ones. Not too many sad faces that I can see, which is good. So yeah, everybody's getting the hang of the technology. So you're getting the hang of the chat box, which is great. There's a wee rainbow coming in, and a blue face. Now, what is a blue? Is that a grimace? The blue one. Maybe not had a good morning at the clinic or whatever. But anyway, it's good fun to see. Somebody's got lots of leftover cake. That's fantastic. Oh, freezing. Sorry, that's what that means. Oh dear. Yeah, there's snow coming, I believe, for some of us. Even in low-lying areas, apparently there's snow forecast. So that's not so much fun. Good stuff. Well, we're getting lots of good. There's a wee monkey face. So here's the next little icebreaker. There's 3 movies using emojis, and we'd like you to select from the emojis, try and pick out what these 3 films are, And again, shove them into the chat box and we'll have a laugh before we get started proper. Somebody's got the first one right. And the second one. Well, maybe we've made it far too easy. The third one's more tricky, I think. I could only do it because I took part in a family quiz for Tiny Tickers, the baby's congenital heart charity, last night, and they had the third one in as one of the questions. So I haven't seen the third one answered correctly yet. Musical frog pig. What's that? The Muppet Christmas movie. I think that might be it. I think somebody's got it now. Anyway, it's all good fun. All good fun. There you are. There's the answers. Did you get it right? Home Alone was easy peasy. Frozen was easy peasy. Muppet Christmas movie, Christmas Carol. We'll give you Muppet Christmas movie. We'll give you that. It's officially called the Muppet Christmas Carol. Well, there you go. Nice Christmas theme to get you in the mood. And now we're going to continue with the programme. And I'm delighted to introduce my ex-neonatal colleague and current neonatal national clinical lead with us on MCQIC, who's going to address us now. Colin Peters is going to address us on presenting the national data overview with respect to term admissions of neonates.
Thanks very much, Alan. And just in case anybody was celebrating, I'm not an ex-neonatal consultant, just an ex-colleague from the Queen Elizabeth. So we're going to talk about the national picture of where we are with term admissions and what work has been done so far, leading into what work is going on in some of the boards that are going to be presenting next. So if we go on to the next slide. So since about 2018, part of the MCQIC neonatal measurement has included the rate of term admissions to the neonatal unit. For those that are interested, it's DO2. It's a part of the sat under the safe, effective and reliable care part of our overarching driver diagram. Essentially, we were looking to see, could we reduce the number of term admissions and the amount of separation of mums and babies, and it was building on work that had been seen in NHS England with the ATTAIN programme, for example, avoiding term admission in neonates, in neonatal units, in fact, and it really didn't distinguish between planned admissions to the neonatal unit and unplanned, and that was a deliberate decision. But we always knew that we were never going to get this down to zero. There was always going to be a background number of babies who were always planned to come to the neonatal unit and always needed to come to the neonatal unit, whether they were planned or not. So they were unavoidable. But this measure included everything. So if we go to the next slide. It's not come up on my screen. Yes, there we go. So there was within quality improvement, we don't really like targets, but within this one, we felt that as a stretch aim that we could be looking to try and see, could we get to a 3% term admissions across the whole of Scotland. There will be some places where that's going to be higher and hopefully some that will be lower, but aiming for 3% overall. So in the next slide should show us what has happened. Oh, no, it hasn't yet. So alongside that measure of outcome, there were some process measures which were there to factor in and contribute towards reducing term admissions. So there's a measure that looked at the identification of at-risk patients. So babies who came in and perhaps there were risk factors for sepsis. Were they assessed as being at risk? Were they put on a news chart? For those that went on a news chart, was there an appropriate action? Was there a correct number of observations done? So that, again, was a process measure to help to identify babies who might be able to intervene early when they scored on their news chart and thereby avoid them having to be separated. Alongside that, we also had the measures around hypothermia and we've seen the warm bundle rolled out around Scotland, and I know that that'll be talked about a bit later on. Again, not just factoring into being admitted because you're cold, but because cold babies have respiratory problems and hypoglycemia, for example. So what does this show us? This shows us that over the last 3 years, from January 2018, if we look at the data we've got available on BadgerNet, now that doesn't include all of Scotland because we don't have denominator data for some units that didn't have, don't use Badger Maternity or haven't throughout the time. So this is a very rough and ready, unratified set of data, but essentially it shows us that we had about 6.8% or 6 to 8 per thousand live births admitted of term babies to neonatal units. And in the last year, we've had minimal impact on that. It is at 66%. Now, it's not the full story because these are babies who are admitted to the neonatal unit, and a decision as to whether a baby is admitted on BadgerNet is perhaps different across the country. For some units, they use being in for 4 hours as a point at which you say this is an admission, and prior to that, it's a short stay or period of observation. But those babies are separated from their parents, and that has an impact on establishing feeding, long-term bonding, and all the reasons that we know that we should keep mums and babies together. So it perhaps doesn't tell the whole story, but if we look at babies who are admitted on Badger, we haven't really impacted on a Scotland basis over the last 3 years. So next slide. So within our measure, it suggested that there are 5 main reasons, and perhaps a 6th listed there, for babies being admitted to neonatal unit at term. So respiratory disease, infection, hypoglycemia, jaundice, encephalopathy, and perhaps hypothermia as a primary reason, but maybe overarching some of those. And you'll know from our sessions in QI over the past few years that thinking about using QI tools, that a Pareto chart as shown on the right might be a thing that you can do in your unit to identify what are the factors, what are the conditions that you might be able to impact which will have the greatest reduction in separation of mums and babies. So if respiratory disease is on the left, that would be the one for you to tackle. Of course, it might be that something over towards the middle is an easy, quick win, then by all means go for it. But I think we need to think of breaking down term admissions into smaller categories and to be able to tackle those as the cause for each of those individually, and where there are some overarching systems and processes that might affect several causes for admission. So next one. What else do we know about our background data nationally? Well, within MAP, it's reported that the number of separation days at 37 weeks or and above for those babies who don't have surgery or are never transferred. Now, what we see here is an average, and in 2017 that was 3.6, then falling to 3.1 and 3.1, and that sounds like there's an improvement. However, if I go to the next slide, we need to think about the story behind the data, not just the numbers themselves. In this example, I've shown some made-up data of number of babies on the y-axis, number of days admitted to neonatal unit on the x-axis. Average in this case would be 5.4 days of admission, for example. Now, if we highlight the babies who are least likely, or the babies who we might be able to avoid their admission, they're probably going to have the shortest stay. So let's imagine then that we have fewer babies who come from 1 day or 2 days. Then what happens, as we see on the next slide, actually our average goes up because they are the least likely to be avoidable admissions. They're likely to have to be in, they're likely to be planned admissions that are going to be staying in for longer. So actually a fall in average duration of admission might actually mean that we're admitting more babies for shorter periods of time. So it's important to understand your data and not just to look at the numbers and think that a fall might be an improvement. It might be that actually we want our average length of stay to go up. So that's a little run through the national picture. and we'll keep updating that as we have been over coming months. I'm going to hand back to Alan for the next part of the agenda.
Great, Colin. Thanks for that. We're happy to take questions for Colin at the moment on the national perspective with regard to term admissions. Haven't seen any through the chat box just yet. Let me have a look. Feel free to put them on the chat box or put your hands up. Do you know if you know how to do that? There's a hand at the top of your control if you want to ask a question.
I'll fill in the gap, Alan, by saying it's worth remarking that, of course, the measures sit under neonatal, but they are, as we've highlighted here, very much multidisciplinary. Yeah. So it's about working between neonatal obstetrics and midwifery to establish what can we do to keep mums and babies together.
Colin, we've got a hand raised from Mary Clark.
Okay, Mary, do you want to come in? You can share your camera if you can feel the need, or just speak to us.
Can I? Am I not sharing my camera? I thought I was.
There you go. We can see you now. Yes. Do you want to
Colin,
your position and where you are, Mary? Would that be okay?
Yeah. So I'm the senior charge midwife in the labour ward in the Queen Elizabeth.
I know that.
Nice to see you, Alan. It's nice to see you. I just wanted to ask, when you're talking about the 5.4 average, is that for everything? That's for the hypothermia, the respiratory, that's for all admissions?
Yeah, so that 5.4 is a sort of fictional example right. of the duration of separation, but just to kind of give an example of what happens if you have fewer short stay admissions, that actually your average duration of admission goes up.
Right.
Yes, and that would, but what we see at a national level, reported in NNAP of the 3.1, is for all term admissions in Scotland who don't have any form of surgery recorded in their bajonet or are never transferred between units, which would suggest that there is a greater level of concern, usually that there's an escalation of treatment. So,
right. Okay.
Thanks, Mary. Any other hands up, Damien?
No, nobody just now.
And there's no other questions I can see on the chat box. Here's a question just popped up.
Oh, Andrew has also got his hand raised. Andrew Powles.
Yeah, I just wonder if you have any insight, Colin, into the differences between a baby with its mother on a neonatal unit or in a rooming in, in a rooming in suite in a mother and baby room in a neonatal unit, or a ward-based transitional care, or just a mother who's an inpatient on a postnatal ward who still has a baby with her but has had her stay extended because the baby is getting treatment for jaundice. Those babies might be getting exactly the same treatment in those three locations, but some might be counted as admissions and not, others not. So how do you take that into account?
So if I recall correctly, it depends on what has been selected as their location of care, as to whether or not they are included within the NNAP data, for example. If they're I think most units would not be babies who are with their mother but getting additional care. That's keeping them together. Those that are on transitional care, it depends, I suppose, whether they're using the bajonet system to record their day-to-day. So yes, we know that there are units who have reduced their term admissions by having mums and babies together in transitional care units, and that is what the main purpose of our work is, to try and avoid that separation and deliver care at the bedside where we can, at the mother's bedside.
Okay, there's another question in from Althab. What's the Scottish average when compared to the rest of the UK, considering the work already implemented by NHS England?
That is a very good question, and I am trying to be very, very fast right at this point in time to be able to pull up that data. So because it is anybody can, and I suppose it's worth saying, anybody can go and look at their own data and compare it to the national average units elsewhere in the UK by going on to nnap.rcpch.ac.uk, and that will let them see how they compare. And honestly, I'm not filling for time as I try and bring this chart up on my screen. So at the moment, the national average in 2019 was 2.9 separation days in the UK of term babies. So, but as I said, that actually might not be better. That might be worse, because they might have more babies who could have been kept with their mother, who came for a short stay admission and went back again.
Okay, thank you, Colin. Any other points from around? We're a bit ahead of time, so we can take any more questions if you want, or pop them on the chat box. We've got a couple of minutes. I think we're doing okay. We've got 60 participants now. It's absolutely fantastic. Very, very grateful for you all coming along. And that's the NNAP website just been shared. Okay, we're going to move on, and we're going to hear from Marie McNerney, who's Senior Charge Nurse, Charge Midwife in the Neonatal Unit in Ayrshire and Arran. And Marie is going to talk to us about reducing avoidable term admissions to the Neonatal Unit. Thanks, Marie.
Thank you. Can you hear me okay?
Yeah, perfect.
Lovely. Hi, everybody. Hope you're all keeping safe and well. What I'm going to do today is really just give you a brief overview as to where we are sitting down in Ayrshire regarding our term admissions. Back in September, I was really lucky to join the skills course. We're now cohort 29. And for any of you who've done the skills course, you'll know that a big part of it is undertaking some QI project. So given our organisational and MCQIC priorities, I decided that no better a project to do than looking at reducing avoidable term admissions to the neonatal unit at Ayrshire Maternity. Next slide, please, Sula. So I got behind me a very strong coalition so that they could commit to working with me. And we decided on our aim of reducing avoidable term admissions to the neonatal unit by 30% by June 2021. I know it's a big ask, and I know in this time it's a big ask. COVID's not going anywhere, but QI works. Just waiting on my slide coming up. Has your next slide come up, guys? Are you? No.
No, not yet.
No. We're in a slow boat.
Yeah, sorry. We're just...
No, it's fine. That's fine.
A little Teams hiccup, I think. Hmm.
Yeah.
There we go. Something's happening.
Yeah.
Okay, I think we're back to business, Marie. No.
It's jumped back to Sula. Elaine had it, so Elaine needs to share her screen again.
It's all very technical. I'm glad I'm not in control of it. Okay, this is where we're at. So as I say, I have got a good team behind me, and we had agreed on our aim to reduce the number of avoidable term admissions to the neonatal unit down here, nursery maternity, by 30% by the 1st of June 2021, thus avoiding unnecessary separation of mother and baby. We believe that there may be a lack of confidence and knowledge among the junior doctors and nursing staff who would be the first to review these babies. And we also feel that the existing tool used to identify, assess and monitor clinical progress of the at-risk infant is not quite robust enough to ensure an effective plan of care. Next slide. So the next slide is our data that will come up, and it's probably a very familiar picture across a lot of boards. We see here in Ayrshire quite a substantial amount of term admissions admitted to the neonatal unit. On average, 60% of our admissions per month are term babies. And when we break that data down, primarily they're being admitted from the delivery areas. And a bit like Colin's slide, one of the main reasons for coming into the unit is respiratory symptoms. On a previous study that was carried out within the unit, we looked at the number of babies that were coming into the unit over a 2-month period, the number of term admissions that were coming in for under 24 hours. And what we wanted to do was try and identify if there was any themes happening, but we couldn't. There was nothing shouted out. It wasn't that they were coming in at night more than the day, or it was the wrong doctor that was assessing them. There was nothing in particular that jumped out at us, sorry. But what we did see from that data was 42% of these babies received observation only. So there was no other intervention other than observation. And I think we agreed that 32% probably could have been looked after at the mother's bedside, so 32% avoidable admissions. So what we needed to look at then was to try and understand why these babies were coming in, and we discussed with the stakeholders themselves to hear what their challenges are and see if we could identify any gaps. And their feedback was really interesting, and they kind of agreed a lot in what we were saying, that they felt that the existing tool wasn't quite so robust. They felt that they were getting asked to review these babies time and time and time again, and after the third review felt, well, gosh, we need to admit this baby. It is a difficult call to make, and I certainly wouldn't like to make that call, and you have to be safe, better safe than sorry. But quite often what would happen is the baby would be admitted to the neonatal unit, there would be another set of observations carried out, and then the baby discharged back out to mum. One of the other things that they talked about was they often would bring the baby in for a short, sharp visit, and in their words, sort the baby out, and by doing so, they felt that they were having the baby stay for a shorter period of time. Had they left the baby out in the ward, they feel that the baby would become further compromised and then come into the unit for a longer period of time. So to me, that is a gap. Why are the midwives and nurses on the floor not recognising that this baby needs the attention, the close observation, the early feeding, keeping the baby warm? So is it a knowledge base that they have? Is it an educational need that they require? So that was what we were picking up on the feedback from our stakeholders. Next slide, please. So what we had to do next, now, like all QI work, you start small. So my scope would be just to look at the doctors within the neonatal unit and the nurses based in theatre, because the data was showing me that actually the highest percentage of babies were actually coming in via theatre. And I know that the nurses in theatre are mainly staff nurses as opposed to staff midwives. So again, I was questioning, is there a lack of knowledge there? These staff nurses may not have been exposed to any neonatal teaching. And so what I wanted to do then was conduct a survey for both the medical staff and the nursing staff, just to establish gaps in the knowledge base. And so far, the results that have come in from the survey, we've got a lot of both qualitative and quantitative data, which was really interesting. Yet there absolutely is a gap there in their knowledge base and their confidence levels, and they are actually requesting the teaching session, that they're saying that they would embrace any teaching. So that's really the next step, is to provide teaching sessions around the baby with respiratory problems to both the junior medical staff and the nurses within the theatre. And then we've already designed the new pathway and test that and continue to monitor our data. And that's basically where we are then regarding our babies with respiratory symptoms for the term admissions. Other admissions that are coming in are hypoglycemic, hypothermic babies. We have been working really hard with the warm bundles for our hypothermic babies, and actually for the first half of the year, I was getting so excited because I saw a positive shift in the compliance with the warm bundles, and as the compliance went up, we could see that there was a reduction in cold babies coming in. So I was getting really pleased that at long last we were seeing results of the warm bundles being effective. However, since August, for whatever reason, I don't know, is it that COVID cloud hanging above us or not, but the compliance in the warm bundles has kind of gone to pot, for a better word. And as a result, the number of cold babies are starting to increase again. On a positive note, we have Maternity Badger Net has arrived in Ayrshire, and I have managed to get the warm bundles put on the system, and so there's a box pops up about the to-do list for the babies and the warm bundles in there, so that's a prompt for the midwives to complete the warm bundles. Hypoglycemic babies, we see on average about 2 a month coming through the unit, and at present we're not using glucogel, but there's a lot of discussions and a lot of work going on with an aim to introduce that in the very near future. So hopefully that will have an impact on our hypoglycemic babies. So that's really where we're at down in Ayrshire here. And I know that there's a lot of units out there who have done a lot of work, a lot on what I'm trying to introduce in the project, and so I would actually really value some feedback and any advice and guidance that would help lead our project down here. So thank you very much, and any questions?
Thank you, Marie. That was excellent. We've had one on the chat box, and I think there's one hand raised. Debbie Barnett has said, could cold babies be related to reduction in skin to skin at birth?
In reduction to skin at birth?
That's what she said in the chat box. Maybe you want to come on and explain it more, Debbie, or...
Yeah, I can just say I'm here. Sorry. Yeah, just are you seeing less skin to skin, which is leading to that increase in cold babies? So are babies not getting skin to skin at delivery?
So Debbie, that is really interesting, because I had a discussion earlier about this, but it's almost on the contrary. Skin to skin is happening very well here, but it's actually following skin to skin. Adult babies are coming in cold, which kind of contradicts what skin to skin is all about. But skin to skin will only work in keeping the baby warm if your environment's warm and mum's warm. So we feel that this is a kind of educational thing, not just to the midwives, but also to the parents. Feedback from the midwives when we raise this, they tell us that they're telling the mums, and they're putting the blankets over the baby, and then they turn their back and the blankets are pulled down, and quite rightly, because the parents just want to look at this newborn baby.
Yep, and on that topic, Alan come in and said that she sometimes finds skin to skin is ineffective as the baby and mum are not covered properly, or the windows are open, or the room is cold. Goodness me. Okay,
Yeah.
I don't have a comment.
Lindsay, still, do you want to come in?
Is it Lindsay that's got her hand raised?
It was, yeah.
Yeah.
Hi, thanks. So obviously we've done a lot of work in the warm bundle at the Children's and QE, and we found very similar issues, Marie. So I was just wondering if you considered, again, the themes are all coming through in the questions about your environment. Certainly we saw an initial reduction with really standardised care, improving your thermal processes after babies are born, but then it became a pattern of seasonal variation. So in the colder months of the year, we started seeing more colder babies coming through. And that really triggered us to have to really look closely at the environment, looking at the labour ward temperatures, the temperatures within the corridors, getting the warm cabinets in and the warm cots. So it's just a thought that that might help progress things a bit further for you.
Yeah, no, that is food for thought there, and I think we had discussed introducing the warm cabinets, and obviously these are expensive, so we would all obviously start in an area which needed it most. And I think theatres are certainly, and I know in the chat that people are putting up that the temperatures and the ventilation in theatre doesn't help, so probably one of the best places we could put one. Thank you.
Can we bring in Colin and then Debbie Barnett?
So sorry, it's the kind of switching everything on at the same time. So education, I find, is always an interesting thing. My belief is that education is short if it's delivered as a single entity. Staff move on, new staff come in, etc. So it's great to hear that you're creating a package, because that means that you can then deliver a consistent message. How do you envisage ensuring that if that is one of your tests of change that makes a difference and you start to see fewer admissions, that is then delivered to the next set of staff that come in, or reinforced in the future?
So I think for the medical staff, it could be part of their induction, the teaching session, rather than them learn on the job, that we present that at their induction. The nurses, we are presently providing education around the resuscitation. We provide an hours update, and we're using that platform to talk about our warm bundles and prompt the staff. So there's an area where probably part of that teaching could be put in there in order to sustain it. Yeah. But it is food for thought, and how you sustain it. You're absolutely right. It's keeping it going, because I'm not spending my day going around all the areas.
So I think it's Debbie, is it? Next?
Yeah.
Yeah, and I think the concern is that if skin to skin is being viewed in this slightly negative way as one of the confounders for babies becoming cold, and I think it's really important that we address that consistently, because the last thing we want is these babies not having skin to skin, and then the impact of early feeding, hypoglycemia, jaundice, and so on, which are going to increase your admissions. So I think it's really important to understand that has to be addressed, and as Colin said, consistently.
Yeah, absolutely. And again, that is discussed at resus updates. And I think, and I say that because community midwives come for our training as well. And I remind the community midwives that these discussions should be happening antenatally in community. And when you're talking to the parent about skin to skin and the benefits of it, and to remind them at that point about keeping the baby warm. I've had a lot of kind of heated discussions, if you like, over whether you should have a hat on a baby for skin to skin. And I know that not every baby should have a hat on skin to skin, but if the hat means that the baby, you know, an hour with a hat on as opposed to 4 hours being in the neonatal unit to heat back up is a no-brainer. So they have to think about their environment and making sure that their environment's warm, that mum's kept warm, and that they use the nice warm blankets to keep the baby warm. But we absolutely promote skin to skin 100%. I have to say, even in theatres, they're excellent. The baby's straight onto the abdomen at elective sections, which is lovely to see.
Right, it's a very busy chat box. There's lots of good correspondence on the chat box. There's still another hand up, but maybe yours, Debbie, is a legacy hand, I think we call it. Is there another hand up, Damien? Can you see?
Just checking.
Up, Alan.
Pardon?
It's Angela. I've got my hand up.
Okay, sorry, Angela. Come in.
It's just to make a comment around when Marie mentioned the discussion around hats or not hats for skin to skin. In the excellence in care measure around skin to skin, a hat being on is not an is included, so it's up to the unit and their environment to decide whether the baby needs to have a hat on or not. So if a baby has a hat on, it's still included that you have obtained the skin to skin contact to meet the measure.
Yeah, that's good.
And I think that's really important.
Yeah.
Because, as it's been pointed out, there's all sorts of environmental issues and babies have to move around hospitals, so it's very important that that was included in the measure.
Absolutely. Thanks, Angela.
We've had a good discussion there, Marie. Thank you. There's no other hands up or particular questions that I can see on the chat box. So we'll maybe move on, if that's okay. So the next speaker is Lindsay Still, who's a consultant neonatologist at Greater Glasgow and Clyde. And you're going to speak on term admissions in your unit, I think, Lindsay, is that correct?
That's right. Thanks, Alan. Thank you for inviting me to speak today. I'm sure you know most faces and most names on the chat, but for those who don't know me, as I said, I'm Lindsay Still. I'm a consultant in Glasgow. I work cross-site between the Princess Royal Maternity and the Children's Hospital and have had quite a lot of experience in QI and term admissions and pre-term work. So it's very much a vested interest of mine, and I'm going to chat you through the current status within term admissions in the Princess Royal and the plans for rolling out QI term admission work both in the Princess Royal and across Glasgow and further if people would like. Next slide, please, Sula. So we're going to talk about how at the PR and Princess Royal we define our term admissions, how we're trying to understand the problem as to what's happening and why these babies are being admitted. Also recap the current and previous quality improvement work for term admissions and try to sort of get a stance as to where we are now and where we go next, and then discuss our plans for term admissions across Greater Glasgow and Clyde. Next slide, please. And again, thanks. So at the Princess Royal, our term admission rate is fairly static. So we roughly have between 40 and 50 babies admitted per 1,000 live births, and it works out at a median of 42. And that equates to around 420 babies per month unexpectedly admitted to our neonatal unit, and those are inborn babies. Next slide, please. What's also really important and what we don't capture and badger and potentially don't capture as accurately as I would like is our short stay admissions. So we have a landing pad, what we describe as a landing pad, which is a resuscitator within our HDU, which provides a lovely facility for us to bring babies for any short stay admissions, for any concerns that they've had, whether it's any sepsis, tachypnea or grunting, which has been a great facility over the years, but I think it's a slightly double-edged sword in that it's led to a bit of safety netting and quite a culture of we'll just bring them up and we'll watch them here. And if we look at the numbers, again, I think these are underreported. They are roughly going between 12 and in September we had 31 babies admitted to short stay with various issues, most often short stay respiratory or hypothermia. And of that, the pink line below shows the number of those babies who were actually admitted. So the proportion is very small. So there's around 80% of these babies coming away from their mothers, having short-term separation, potentially invasive procedures, cannulas, nasogastric tubes that might be avoidably separated from their families. Next slide, please. And as the pattern we've been seeing throughout the day, the most common presenting symptom for babies that are fully admitted, this is full admissions onto Badger, are respiratory. Secondly is a bit of a combination of things like jaundice, HIE and NES. And then we're seeing the usual pattern of hypoglycemia, sepsis and hypothermia. Although from this it looks like hypothermia is the kind of least important condition we're seeing, actually, although it might not be the presenting symptom that the babies are primarily admitted with, when we look back at the data, up to 20% of all admissions are actually hypothermic when they come in, despite that not being their presenting feature. So hypothermia has a role in all of these, and I think more important than sometimes the data captures. Next slide, please. Thank you. So when we look at, we're trying to drill down as to why are these babies coming in, where are they coming from, and help inform us to our pathways and our processes that we can do to try and minimise it. So at the Princess Royal, the majority of these babies are coming from labour ward, and certainly within the first 6 hours of birth. And within that green cohort of 6 hours, the majority of that is actually within the first 2 hours. So it suggests a really early problem of what's happening just after babies are born that we really need to target. And although some perceptions might be, oh, elective sections, grunty babies, actually you can see from the mode of delivery chart that these babies are being born by a variety of different methods. Next slide, please. So when we think of the avoidable term admissions, which is really where we need to target, we're not going to stop the babies that have got severe respiratory distress, the compromised babies at birth, and all of the severe jaundice babies coming to the unit. We're trying to basically reduce the amount of babies who come to the unit that could potentially stay with their families. And really, I think the crux of this problem is to do with failed postnatal transition. So we've got babies that are coming out from a kind of environment of intrauterine placental support where they've been kept warm, they've had a continuous supply of transplacental glucose with minimal oxygen consumption, and all of a sudden the cord is cut, the baby's out, and they have to very quickly adapt and achieve normothermia, normoglycemia, and effortless respiration. And in order for this to happen, the babies need adequate oxygenation, adequate glucose, and an adequate body temperature. And if for any reason any of these things aren't achieved, babies will struggle to transition. And that's the most crucial period in the first 12 hours of life, where babies are most at risk of iatrogenic complications, and where I think we really need to target what we're doing in terms of quality improvement. Next slide, please. So babies have to obviously adapt from a respiratory perspective, they have to adapt from a thermal perspective, and as well as metabolic side of things. And certainly people might think of these individually, but I think it's really important that we need to consider them together, because the physiology of these is very much interlinked and need to be considered as a sort of holistically. And next slide. And this goes on nicely to the neonatal energy triangle, which is a concept I think people are largely unfamiliar with. I think it's a really nice conceptual framework that gives us a lovely integrated overview of the 3 most common newborn problems that we're seeing. Now, we're all very aware that hypoglycemia, hypothermia, and hypoxia are individually have detrimental effects, but as the physiology of them is very much interlinked, I think we all need to rethink our thought processes at times and make sure that if we are reviewing babies for hypoxia, we need to think about checking their temperature and their blood sugar as well. And it allows us to identify, if we're considering these things early, it allows us to identify and treat these babies to avoid further deterioration and poorer outcomes. So in case this doesn't make sense, I'll briefly, you don't need to understand all the physiology, but for those, just to recap it. So for example, if you become cold, babies are going to increase their metabolic rate, they're going to increase their oxygen consumption, increase their respiratory rate, and at a tipping point will come where their oxygen demand will exceed their supply. Babies will switch from aerobic to anaerobic metabolism, become acidotic, and then that leads to hypoxia. Similarly, at the same time, if you're using up your you've increased metabolic rate, you're going to use up more of your glucose stores. And then eventually, if the compensatory mechanisms aren't enough, babies will deplete their glycogen stores and become hypoglycemic. Similarly, with an increase in brown fat metabolism from babies being cold, they will release more free fatty acids, contributing further to the acidosis, which, if allowed to progress and without any intervention, the baby's surfactant production is inhibited. Pulmonary vasoconstriction can then increase as babies can have further respiratory distress and can worsen the hypoxia. So for considering one of these things, we need to think about all of these things together to make sure that we're not missing anything. And I think for the junior staff on the ward, for midwives in the postnatal wards, if we have an increased awareness of these almost expected problems, and these are very much problems of term babies, but most particularly of the late preterm population, where they've got less glycogen stores and less brown fat stores. If we're almost anticipating these problems, we can recognise them early and initiate earlier management to improve the baby's outcomes in these situations. Next slide, please. So I'm just going to have a quick look at where we are in terms of term admissions. We've talked a little bit about them so far, and everyone's doing great work across the country. Bundle looking at the not only standardising the care, the thermal care of babies, but also looking at really closely about the environment. And we've also got Unite doing great work in terms of education and developing of pathways, Curian with the skin to skin, and within the children's, again, the Go To Mum project, which has been a lovely piece of work, which has dramatically reduced respiratory admissions and early separation. And that's trying to weed out the babies who are a bit grunty but well with normal SATs and not working particularly hard, to have a bit of enhanced care within the postnatal ward, and eventually can obviously stay with their families. And that's there's kind of a lot of the Scottish work that's been done, and then there's not to forget the English work, including Attain and Keeping Mums and Babies Together, which is about early risk identification and kind of assessment of respiratory distress and trying to keep these babies together as well, and that's resulted in reduction in term admissions from down south as well. Next slide, please. So how can we pull all this together and really work, kind of bring the themes that we're seeing? So I think we can all agree that things like Warm Bundle and Curian and all these different things that are getting done, we're all focusing on the same types of care. We're all talking about the environment, we're all talking about skin to skin, educating families and parents, and a very much a multidisciplinary approach. So we're trying to sort of pull all the work from this together so that we're not just concentrating on hypothermia alone, we're concentrating on bigger picture, which in the end should hopefully reduce all three and more kind of the other causes of term admissions. So our aim is to be reducing term admissions, avoidable term admissions, by 30% in 6 months. And our driver diagram shows the key primary drivers of our environment, thermal care, feeding, identifying and acting on the risk factors, and also the culture. And the culture I talk about is that separation culture of the safety netting babies that just bring them up to the unit, we'll have a look at them here, and we really want to very much be moving away from that. And that's obviously very much underpinned by a lot of multidisciplinary teamwork. So we're looking at the environment, as I said, the warm cabinets, warm cots, standardising that early care. Key point is to have parents on board so that the parents aren't undressing the babies, stripping them off for their pictures. Early baths are a no now. We've got pathways in place, like the respiratory pathways, but we're trying to find simplified pathways like hypothermia pathways, so that instead of the phone calls up to the neonatal unit for borderline cold babies, having nice simplified pathways for cold babies and for grunty babies that are in place to try and minimise that early separation. All of this is underpinned by awareness and education, and that's something that we are in the middle of developing as an educational package that can be rolled out and shared widely if need be. And hopefully with kind of improved teamwork and support and communication, that can all help towards this. Next slide, please. So pulling this all together and following on from the preterm wellbeing package poster, which we developed last year, and we're looking to develop a term wellbeing package, which again is pulling on the themes people have been talking about and really focusing on the environment, optimal cord clamping, skin to skin for all babies, regardless of mode of delivery, and optimising skin to skin and how best we can perform that, with a focus on thermal care, feeding, and identifying and managing the risk factors, as I've mentioned. Altogether, hopefully, that is really going to keep much more mums and babies together. And that's our plan, very much to roll out. These are not kind of new practices. These are very much established practices that have been proven to work. So we're going to get this ball rolling in this and initiate this across Greater Glasgow and Clyde in the coming months, weeks to months, I should say, and happy to share further if anyone would like. That's us.
Thanks, Lindsay. That was great. We have around 10 minutes for questions. I'm seeing one from Una. Nice to hear from you, Una. Question for Lindsay. Do you have a breakdown of the gestation of the term admissions? Was there a near-term group, 37, 39?
Certainly in this, in the most latest cohort of data, no. But I have seen when I previously looked at the data, certainly a predominance of more 37 weekers, and obviously our term data doesn't capture the late preterm babies, so I think it's really important that we keep that in mind. But at the moment that didn't reflect that, but I think we need to, if we're going to be concentrating the postnatal ward, the late preterm babies are the highest risk, and we need to think about kind of approaching them as a more vulnerable baby.
And then there's a question from Amanda Gotch in Grampian, who says, when does a short stay become a full admission?
Yeah, so generally across most units, I think in the West of Scotland, it is more than 4 hours. So babies can come down for a period of 4 hours, after which they need a decision whether or not they're going back to their mum or whether they're going to stay and be fully admitted through Badger. Is that not something that is done throughout, Amanda? I don't know if you want to come back in on that.
And I think Colin's posted a reply, so that's substantiated your reply, Lindsay. That's good.
Yeah, I was going to say that's what we do in Grampian as well. I think I just wanted that confirmation that we're all kind of doing the same thing. So yeah, thank you.
I'm not sure we can confirm it though, Amanda.
All right, okay.
Some units who will put onto Badger shorter admissions, but yeah, as we said in the West, that was from our data group. We recommended that it was the 4 hours.
4 hours, yeah.
Equally, and also because there is a cost to the health service for every admission onto BadgerNet. So there's a little bit of, if you're going to be coming and going, is there value in that additional cost? It's not the only thing, but it is one of the.
Thank you.
Great. There's lots of responses coming in the chat box. Most of them seem to be about 4 hours, so that's good. Any hands raised at all, Damien? Have you come? I haven't seen any.
Not yet.
All right, we've still got a few more minutes, so if there's any other further thoughts on this topic or previous topics, you can fire away. Use the chat box or raise your hand. Don't be shy. We're here to have a good conversation about this. Mary, what are you saying? The Go-To Mum project and the Keeping Mums and Babies Together is work ongoing in the QE, and that they're happy to share any learning and success with any other unit. So that's good. Okay. We've still got 63 on my little screen, tells me. Colin's got his hand up. Colin's going to.
I do. I thought it's worth maybe remarking on the avoidable and unavoidable question. The deciding whether a baby's admission was avoidable is somewhat subjective. The baby who reaches a level of jaundice that then is admitted to neonatal unit, some would say is avoidable. However, for some of those babies, actually early identification of risk factors, starting phototherapy on the postnatal wards, thinking about having double phototherapy in the postnatal wards, which in some places isn't delivered, or different mechanism of phototherapy, for example, might change that narrative from, sorry, I've got a dog appearing, from what we currently think is unavoidable to actually being avoided. And hence that one of the reasons we're talking about planned versus unplanned admissions, the babies that we know from their antenatal care need to come to neonatal unit, and accepting that we won't necessarily be having no babies who are admitted who we think we could avoid them all. So yeah, taking out the subjectivity.
Thanks, Colin. Okay, so I don't see any other raised hands or anything else in the chat box. So once again, thanks, Lindsay. That was excellent. We'll move on.
No problem. Sorry, just to come on, I'll have to ask the important question that we did talk about earlier this morning when we were chatting, is should we start badgering the short-term admissions for collection? Colin, I might put that to you.
I think I would say no to that. I think that yes, having good data around it is important. However, if you do start putting all of those on, again, there's a time to have a comprehensive and complete badger record for each baby, which may well outweigh the benefits, especially if you are having quite a number of short stay admissions because of the way you practice. I think robust data collection, yes. Badger net for very short ones, possibly. I would recommend no.
Okay, there's a couple of comments just appeared in the chat box. One just around what you've said, Colin, and then Carol, sorry, it's got wiped. What does it say? About babies with antibiotics, do not get separated from mum. Okay, sorry, I don't think it's particularly a question.
Yeah, I think it's more a remark on things that are done. But once babies are on antibiotics, then they're not brought to the neonatal unit to have the antibiotics given. I think, if I'm right, Lindsay, they do come to get their cannula put in the Princess Royal, and other units are delivering that differently, depending on what you can establish.
Yeah, that's right. They're not measured as part of a short stay admission, but they do come for their cannula and then they get the rest of their antibiotics up in the ward. Yeah, that's right.
There's a question about Badger, Colin or Lindsay, about is the TC part in Badger an extra cost?
Any episode on BadgerNet has a cost if it's an admission in neonatal Badger. If you're keeping the record within maternity Badger, then that is already part of the woman's record.
Okay. Okay. Right. Well, I think it's possibly time to introduce my midwifery colleague. Yeah. So Angela is going to speak next, who's our midwifery national clinical lead in MCQIC. And Angela's going to cover some future topics, and it's really just for open discussion. Over to you, Angela.
Thanks, Alan. And good afternoon, everybody. Thank you. This has been a really, really interesting session. So thanks to everybody for all their comments and contributions. It's been great to follow the discussion. Can I have the next slide, please? So this is really over to you. There's no such thing as a free lunch and there's no such thing as a free webinar. What we really want from you, we've already discussed with the community about how often you want the webinars, but what we need from you now is what you want the topics to be. What topics linked to our programme would you like to see discussed moving forward into 2021? Some of those will be joint maternity and neonatal ones because the subjects are so intertwined. Some of them might be purely neonatal, some might be purely based on the maternity work that we're doing. But what we need is suggestions from you. You can pop those either into the chat box just now. You can put your hand up and suggest things, or for those that like to think about it for a bit longer, we can you can pop it into the MCQIC inbox by email. But we would really like some ideas from you and what we can do. And particularly, I mean, Damien's just popped in, you know, what QI work are you doing around it that you can share with us? the purpose of these webinars is an all share, all learn, which is what we've been doing from GG&C and Ayrshire and Nairn today. And it's very important that we go on doing that, sharing all the good practice, the work that's carrying on and learning from each other. So what have you got? What are you working on? What can you share? What do you want to start doing that colleagues might help you with and can help you take forward? So anything that's going on would be very helpful. And I can see there's a couple of comments coming in around discharge planning, around PPH. So some of these will be very much based on individual maternity or neonatal, but always remembering we have to keep the topics going as well around our joint webinars, so we ensure that to get the best outcomes for mums and babies. It doesn't do mums any good to separate them from their babies either. So it doesn't help the baby, help mum, it doesn't help that whole family unit. So ideas please from you all around how we can take this forward. So can I have the next slide please? So while you're thinking about it, what we want to do is just make sure that you all know that the BAPM have a webinar coming up. It's on, I think it's the 7th of December, and it is from 2 till 3:30, and it's around optimising, if I remember, early maternal breast milk for the preterm infant. So that will be of interest to both maternity and neonatal. If you go on, the toolkit has been published. I had a quick glance through it last night, looked really interesting. And for those in the maternity side that might not be in the habit of looking at the BAPM toolkits, the antenatal optimisation for preterm infants is there. They've obviously just published their early maternal breast milk. And the one that is of really interest around the topic we've talked about today is their improving normothermia in the very preterm infants. But when you actually look at that toolkit, a lot of what they've got in there of their ideas and the prompts and things you can think about and how to bring it all together is what you will be doing in your work around term, reducing term admissions around normothermia. So it's worth a look from that point of view as well if you're just starting to get going and wondering where to start your work, discuss it with your colleagues, what's the first step in your unit to take forward. The link to the BAPM webinar is being put into the chat box, so you can follow the link from there, because obviously you can't do it on this slide. Any questions, comments, anything that anybody wants to pick up on around that?
No, there's been quite a lot of activity in the chat box, good suggestions. So we'll, as you know, we're recording this, so we'll take all these on board.
Nobody wanting to put their hand up and talk about what they, or mention what they want to say at this stage, just wanting time to, you've either put it in the chat box or you want time to reflect.
Yeah, feel free to raise a hand if you wish, otherwise just pop it in the chat box, as Angela says.
Angela, I think there are some things in the chat box. Hazel has mentioned natal discharge planning and community liaison. There's anything to do with reducing PPH in theatre.
Yeah.
Very topical. Yeah. A wellbeing package, MagSoft administration. Alison, you'll know that we've done our magnesium WebEx well, fairly recently, with some of the precept work in there, and that should be available on our website, if I remember rightly. And that is included in the antenatal optimization work that BAPM's got.
Okay, if there's
and the induction of labour was was mentioned, and that's one of our aspirations. So yeah.
If there's no other questions, then I'll hand back to yourself, Alan.
Okay, that's fine. Well, we're nearly at the end, and we've had a really good hour and a quarter actually of good discussion, great topics, great presentations, and I'd just really like to thank the speakers who've contributed today, and you as the audience that have put time aside to come And we're still getting lots of chat box entries, so that's great to see. I think this forum actually works very, very well. We are going to do a word cloud. That's the other thing we're going to do. We're so innovative, I tell you, quick. We're going to ask you to let us know one word how today's webinar went by using the chat box. So you've contributed lots, but give us some thoughts in words, and we'll create a word cloud. I'm not really sure I know what a word cloud is, but yeah. But somebody will make a word cloud out of your words. So we'll give you a minute or so to do that. But very big thank you to all the speakers and all of you that have helped to make this a very useful webinar. And we hope to have a series of these running for the next few months. And we'll keep you well informed about when they're coming up. And the fact you don't have to travel for this educational purpose is great, isn't it? I mean, it makes a huge difference that you can just get near a PC and plug in and off we go. It's made life hugely different for us from an educational perspective, and I hope that McQuick will continue to do webinars like this. And obviously, it's no substitute for the face-to-face and meeting people and going for coffees, etc. But it's a very good substitute, I think, and it works exceedingly well. So I'd also like to thank our organising team at McQuick, who've done a sterling job putting all this technology together and keeping it running very smoothly. So there's lots of good words. There's lots of networking, I think, coming up. So that's good. But I have to say, I miss the going for a coffee type networking. But one fine day we'll be back to that forum. And I think the combination hybrid is certainly the way medical conferences, I think, will go in the future. Some kind of locality where people can get together, and then the ability to dial in and to VC as well. So, and the fact you can look at things at your leisure is also a huge benefit to these virtual meetings. So thanks everybody for contributing. I think I've done enough chat. If any of my colleagues from McQuick or any of the speakers want to add any more words, put their camera on and their mics on and come and say hi.
Thanks, Alan. It's probably worth saying that we have recorded this, and so you'll be able to share it with your colleagues if you want to in the future. If there's anything that you want to ask, then please, directly message on Teams. You've got the if you've typed in this chat, then I think you should see the other people that have been involved in the chat. So yeah, I'm happy to answer any questions as ever.
Just say thanks to everybody for joining us, and thanks for all the chat and the chat box and all the suggestions. That's really helpful for us moving forward. So thank you all very much.
Yeah, very much appreciated. Well, we're nearly on time. We've got about 5 more minutes to go, but I'll let you go. Numbers are dropping a little bit, but it's been great to see everybody, sort of. Virtual C, we do this C. So yeah, thanks again, and we'll be in touch when the next webinar is planned through the McQuick team.
Thanks, Alan.
Okay, thank you, everybody.
Thank you. Bye-bye.
Bye.
Bye-bye.
Somebody has control that can switch us off.
Thanks, everyone. Bye now.
Bye.